give a good overview of the approach to current UTIs. So good morning, everyone, and thanks for the opportunity to present on this platform. I'm Shil Chetty, and I'm a third-year registrar at Tigerbrook Hospital. So today I'll just be giving a brief overview on your current UTIs in terms of the approach, pathogenesis, and treatment and preventive strategies. It's quite a broad topic, so I'll try and be as concise as possible and not take up too much of everyone's morning. So let's start with the incidence and epidemiology. The incidence and epidemiology of the recurrent UTIs exhibits why it's such an important pathology for us to identify. So UTIs are considered the most common bacterial infection, and in the US, the UTI-related complaints are the most common diagnoses for women visiting the ED. Approximately 30% of women would have had at least one symptomatic UTI requiring antimicrobial therapy before the age of 24, while approximately 50% of women would have had experienced one UTI in their lifetime. In the USA, there's 11% of women above the age of 18 experience at least one UTI annually, and the self-reported incidence of cystitis in women is 12.6% per year and in men 3% per year. This incidence infers a significant financial impact. In the USA alone in 2010, the cost of UTI treatment was $2.3 billion. In 2013, there was a web-based survey in Germany, Switzerland, Poland, Russia, and Italy that sought to qualify the morbidity and social burden amongst adult females who experience recurrent UTIs. Among the 1,941 participants, the study reported a mean of 2.78 doctors' visits per year, 3.09 sick leave days per year, and 3.45 days of limited activity per year, again highlighting the economic implications of recurrent UTIs. Once a patient has had a UTI, he or she is likely to develop subsequent infections. The probability of recurrent UTIs increases with the number of previous infections and decreases with the elapsed time between the first and second episode. A patient who has had 2 infections within 6 months has only 33% probability of remaining infection-free for 6 months. In healthy college-age females, 20% had at least one culture-positive documented UTI within 6 months of index UTI. Other studies have reported a 20 to 30% recurrent rate in females. This overall highlights a negative impact on quality of life that includes reduction in quality of social and sexual relationships and negative impacts on the workplace, and also highlights that women are disproportionately affected. So now that I've defined UTI, or rather now that I've touched on the incidence of UTIs, it's important to kind of define what a UTI actually is. So UTI is defined as an inflammatory response of the urothelium due to bacterial invasion that is usually associated with bacteria and pyuria. What is bacteria? Bacteria is the presence of bacteria in the urine that can be suggestive of either infection or colonization and can present symptomatically or asymptomatically. Pyuria is the presence of white blood cells in urine, which is generally indicative of infection or inflammation of the urothelium due to bacteria, stones, or other indwelling foreign bodies. Bacteria and no pyuria is more suggestive of colonization, while bacteria and pyuria is suggestive of infection. Pyuria alone or sterile pyuria is suggestive of other causes like calculi, TB, and neoplasms. So regarding the classification, now that we have defined what they were, we can classify urinary tract infections based on a few different criteria, namely the site of origin, the timing, as well as host and bacterial factors. UTIs can be classified clinically by their presumed site of origin, either as acute cystitis or acute pyelonephritis, to name a few. UTIs can also be classified in terms of the anatomic or functional status of the urinary tract and the health of the host. As we know, they can be classified as complicated or uncomplicated UTIs. Uncomplicated UTIs are basically infections in a healthy patient with a structurally and functionally normal urinary tract, while a complicated UTI is a clinical syndrome characterized by pyuria and a documented microbial pathogen culture of urinal blood, accompanied by local and systemic signs of infection that occur in the presence of a functional or anatomical abnormality of the urinary tract or in the presence of catheterization of a patient. Just to throw a little span in the works, the EAU guidelines of 2025 changed the nomenclature, so it's no longer known as uncomplicated and complicated UTI, but rather localized UTI and systemic UTI. So localized UTI is UTI or cystitis without any signs or symptoms of systemic infection in either sex, while a systemic UTI is a UTI with signs and symptoms of systemic infection that can be fever, rigors, chills, with or without local symptoms originating from any site in the urinary tract in either sex. Moving on, UTIs may also be classified by their relationship to other UTIs. This is where the definition of recurrent UTIs come in, which is essentially more than 2 episodes, which is culture positive, in 6 months, or more than 3 episodes in 1 year. It can be further classified or subclassified into reinfection and bacterial persistence or relapse based on the pathogenesis of recurrent UTI. So reinfection, which is the most common way recurrent UTIs manifest, is essentially a recurrent UTI associated with a new episode caused by a different bacterial strain or the same strain after complete clearance of the previous infection, and typically occurs more than 2 weeks after the previous infection or after documented sterile urine culture between episodes. In terms of mechanism, it's suspected that new bacterial exposure from the periurethral, vaginal, or gastrointestinal sources may be this cause, and it's often linked to sexual activity, poor parental hygiene, estrogen deficiency, etc. As mentioned, microbiologically, it's usually a different organism that reinfects the patient, and this suggests new introduction of bacteria as opposed to fatal eradication or pre-existing nidus. In terms of bacterial persistence and relapse, basically, these are recurrent UTIs caused by the same bacterial strain without a sterile urine culture in between, suggesting that the infection has never fully been cleared. It usually occurs within 2 weeks after completing antibiotic therapy. The mechanism of this is suspected to be due to incomplete eradication, secondary to a whole host of things, including inappropriate antibiotic choice or resistance, structural or functional abnormality of the urinary tract, or foreign bodies. It basically implies there's an ongoing source of infection and there's a nidus that needs to be investigated and surgically explored and removed. Again, EUA guidelines have thrown another span in the works and changed the phrasing or the rather nomenclature of this. It's no longer referred to as recurrent UTIs, but rather recurrent cystitis. The implication of it meaning that the upper tracts are normal and there's no systemic signs of infection. But the timing or the criteria remains the same, with more than 3 episodes of cystitis in 1 year and more than 2 episodes of cystitis in the last 6 months. Moving forward, just regarding the investigations and treatment, I will use the terminology interchangeably with recurrent cystitis and recurrent UTIs because most of the older articles and literature still refer to it as a recurrent UTI. So moving on, the pathogenesis of UTIs. UTIs are a result of interactions between the uropathogen and the host, and occurs when the normal flora of the host are replaced by uropathogenic bacteria. Successful infection is determined by virulence factors of the bacteria, inoculum size, inadequacy of host defense mechanisms, and abnormality of the urinary tract. Most bacteria enter the urinary tract from bowel and skin reservoir and is sent via the urethra into the bladder. The adherence of pathogens to the introital and urothelial mucosa plays a significant role in the pathogenesis of UTIs. So what pathogens are actually ones that precipitate UTIs? So most of them are facultative anaerobes, mostly from bowel flora, and neuropathogens like Staph epidermidis and Candida albicans can originate from the vaginal or perineal skin. E. coli is the most common cause of UTI and causes 85% of community-acquired and 50% of hospital-acquired infections. Other organisms that are involved in community-acquired UTIs are gram-negative Enterobacteriaceae, gram-positive Staphylococcus faecalis, and Staph saprophyticus. While the organisms that cause hospital-acquired UTIs include, other than E. coli, Klebsiella, Enterobacter, Citrobacter serratia, and Pseudomonas aeruginosa, just to name a few. Now, uropathogenic E. coli is responsible for 75% of uncomplicated UTIs and 65% of complicated UTIs, and it's different from the just run-of-the-mill E. coli in the sense that it has adopted virulence factors or mechanisms that allow them to proliferate and cause disease in sites outside of the intestinal tract. So in terms of the UPIC pathogenesis, which is for the basic sciences registrars, a very common question being asked, UPEC microorganism colonizes the periurethral and vaginal tissue and the urethra. It then ascends into the bladder lumen within the urine and adheres to the surface of the urothelium and interacts with bladder epithelial cell defense mechanisms. It then forms a biofilm that protects itself from antimicrobials. Subsequently, it invades and replicates and forms intracellular bacterial communities, or IBCs, in which quiescent intracellular reservoirs can form and stay dormant. Eventually, there may be fluxing of the bacteria back into the lumen that can cause secondary reinfection and IBC formation. And this is generally how recurrent UTIs can form, especially when they subdivide into reinfective causes. So UPEC microorganisms have virulence factors, which provided with a particular set of skills used to invade the urinary tract. One I would like to highlight are these finger-like projections called fimbria with an adhesive tip called FIM-H that allows it to attach to the urothelium and form catch bonds, which prevents its expulsion in the presence of the hydrokinetic effects of urine. There are other types of fimbria like P, S, and curly fimbria as well. Other virulence factors of note are siderophores, which plays a role in iron sequestration and providing nutrients for the UPEC microorganism, and the lipopolysaccharide layer that's an immune response activator. I mean, as you can see, the UPEC is almost perfectly designed to invade the urinary tract with all these virulence factors, which I will not go through just to save some time. So pathogenesis is also dependent on the interplay between these virulence factors and host natural defense mechanisms. Along with fimbria, there are other virulence factors that promote bacterial adherence, which is a critical point of UPEC pathogenesis. So bacterial adherence to vaginal and urothelial epithelial cells are an essential step in the initiation of UTIs, and it's influenced by adhesive characteristics of bacteria, which we've already mentioned, receptive characteristics of epithelial surface, and fluid bathing, both surfaces, which urine does. So the epithelial cell receptivity of vaginal cells. So there's an increased adherence of pathogenic bacteria to vaginal epithelial cells, and an increased number of receptor sites for UPEC on epithelial cells in women with recurrent UTIs. There's variation in receptivity to UPEC microorganisms, which is related to estrogen. Susceptibility to recurrent UTIs is increased by lower estrogen levels found in postmenopausal women. And thus, estrogen replacement does decrease uropathogenic bacterial colonization and the incidence of UTIs. I'll touch on that a little bit more in the treatment and prevention of recurrent UTIs. The host is not completely defenseless against these microorganisms and has a few mechanisms to prevent colonization. So in terms of the periurethral and urethral region, normal flora of the vaginal introitus, periurethral region, and urethra contain microorganisms which form a barrier against against colonization, which Dr. Theron did touch on. So these include lactobacilli, coagulase negative staph, Corynebacterium, and streptococci. Changes related to estrogen, cervical IgA, and low vaginal pH may alter the defense. More commonly, antimicrobial agents and spermicidal agents can increase receptivity of epithelium for uropathogens. Urine itself has protective properties as well, with the hydrokinetic effects of urine flow, allow the flushing of bacteria and the emptying of the bladder as well. Urine also contains inhibitory factors like osmolality, urea concentration, organic acid concentration, and urinary pH. It also contains proteins like uromodulin or tan-Horsfeld protein, which saturates all the mannose binding sites of type 1 pili, which essentially assists in blocking bacterial binding to the uroplakin receptors of the urothelium. The bladder itself also has protective mechanisms. It is able to empty, thus leaving no urine behind to provide a culture medium for bacteria. And atomically also has a glycosaminoglycan layer, which is a negatively charged polysaccharide layer that covers the luminal surface of the bladder and is thought to provide a barrier against these microorganisms. The immune response. So the host immune response occurs as a result of interactions between pathogen-associated molecular patterns and that are contained on the lipopolysaccharides of bacteria and toll-like receptors in the bladder lumen. So the toll-like receptors of the bladder lumen or the bladder acts as sniffer dogs that detect the scent of PAMPs. They alert the host so that the immune system is triggered. You first have your innate, then adaptive immunity. The innate immune response causes local inflammation, while the adaptive immune response sends T and B lymphocytes to fight infections. Just to keep that brief. Unfortunately, the UPEC pathogen is quite resilient and adaptive. It is able to modify these Toll-like receptor ligands and suppress the inflammatory response in order to create a window of opportunity where it can further invade the urinary tract. It can also induce exfoliation, which actually seems counterintuitive, as it could potentially displace the bacteria too, as a result of sloughing of the superficial damaged cells of the urothelium. However, when this occurs, it allows the microorganisms to move deeper into the urothelial cell layer and form quiescent intracellular reservoirs. So again, UPEC is quite smart in how it's able to avoid and manipulate the host immune system. So alterations in the host defense that also feed towards the pathogenesis of recurrent UTIs is urinary tract obstruction, vesico-ureteric reflux, underlying diseases like diabetes, HIV, conditions like menopause, pregnancy, and spinal cord injuries with high pressure bladders. Okay, moving on. In the evaluation of patients, particularly women with recurrent UTIs, the clinical focus should be on preventing recurrences by identifying risk factors for and altering behaviors that contribute towards recurrent UTIs. The history and physical exam should also eliminate overt anatomic or functional abnormalities of the urinary tract that predispose to recurrent UTIs. Focusing quickly on the history, a focused history taking with emphasis on ascertaining the prior number of infections and the frequency, as well as cultural results, associated symptoms, and identify risk factors or triggers should be done. The risk factors for recurrent UTIs, just to name a few, are sexual activity, a new sexual partner, a family history of UTIs, recent antimicrobial use, spermicide use, history of UTI before menopause, and incontinence, elevated post-void residual and cystocele. Just with spermicide use, the reason why it's actually a risk factor for recurrent UTIs is that it contains its active ingredient is naloxone 9, which is toxic to lactobacilli, but not to E. coli, which predisposes it to developing or being colonized by E. coli rather. On the physical exam, palpating the suprapubic area and performing a pelvic exam are important. It is also important to perform a vaginal exam to evaluate appearance of the vaginal epithelium, particularly in postmenopausal females, and exclude the presence of pelvic organ prolapse and urethral diverticulum that could establish a risk factor or cause for recurrent UTIs. Just moving on to side room investigations, urine dipstick is urine dipsticks with a positive nitrate or positive leukocyte esterase on blood on dipstick most accurately diagnoses a UTI. In premenopausal females with a functional uterus, it is imperative to ask whether they may be pregnant. And in many patients that we do in our OPD, post-void residual and uroflow measurement provides important information. It was found that in postmenopausal females with recurrent UTIs, higher PVRs and decreased urine flow were associated with a higher risk of developing uncomplicated recurrent UTIs. Okay, now regarding the special investigations and more invasive investigations, obtaining a urine MCS in the evaluation of recurrent UTIs is crucial. Many of these patients are treated based on symptoms that overlap significantly with irritative storage symptoms and may in fact be inappropriately treated with UTIs. Less than ideal if you want to have good antibiotic stewardship. It is therefore important to establish that their symptoms are secondary to bacteria and to quantify the bacterial burden, species, sensitivity, and degree of resistance. So historically, a colony count of at least 100,000 colony-forming units per mole was used to diagnose a UTI. Initially, the colony count confirmed a diagnosis of pyelonephritis, but has subsequently been employed to make a diagnosis of cystitis as well. However, there's many studies that have demonstrated that females with dysuria may have lower bacterial colony-forming counts between 100 to 10,000 colony-forming units per mole, likely due to slow doubling time or frequent bladder emptying from irritation. Thus, in patients with dysuria, an appropriate threshold for defining significant bacteria is 100 colony-forming units per mole of a known pathogen. Okay, then moving on to more, again, invasive... moving on to more invasive investigations. Imaging and cystoscopic evaluation are not warranted in all females with recurrent UTIs. Indeed, the yield of imaging in females without suspected complicated UTI is low and is not recommended by the EUA and AUA. However, in women with risk factors for complicated UTI, the evaluation should include imaging and cystoscopy. These diagnostic tests may reveal kidney or bladder stones, neoplasms, fistula, anatomic renal abnormalities, including scarring or papillary necrosis, or many other possible abnormalities. So in terms of what imaging investigations we have at our disposal, we have abdominal X-ray and ultrasound KUB that can assist us to assess if there's bladder calculi, or ultrasound to assess for pyonephrosis or hydronephrosis. A CT can be useful if there's a negative ultrasound KUB or if there's a suspected anatomical abnormality. A micturating cystourethrogram can assess for vesico-ureteric reflux. A retrograde urethrogram can assess urethral strictures, although this is more helpful in males. And a pelvic MRI can assist us in assessing the pelvic soft tissue and the urethra to exclude urethral diverticulums. Urodynamic studies may also be helpful, and cystoscopy can give us a quick overview of the bladder. So the indications that warrant these kind of investigations would be patients that had previous urinary tract surgery or trauma, if there's a previous bladder calculi, renal calculi, if there's gross hematuria, if there's bacterial persistence, new maturia, a patient has underlying diabetes mellitus, or repeated episodes of pyelonephritis, just to name a few. What is important here is that not all uncomplicated recurrent UTIs warrant workup, such as imaging cystoscopy, because the diagnostic yield is low, but those presenting with atypical symptoms warrant further investigation. Okay, so moving on now, just in terms of the management prevention. So just in terms of how to do it algorithmically, essentially we can start off with the treatment of the acute episode, along with correcting the abnormality or underlying anatomical abnormality present. Then we move on to prophylaxis, which can include lifestyle modification and prophylaxis with non-antibiotic and antibiotic means. So the majority of females with recurrent UTIs do not have identifiable or correctable anatomic abnormalities. And the options for minimizing recurrent UTIs include behavioral modifications and the like. Because of the chronicity and impact of quality of life of recurrent UTIs, clinicians must integrate their patients on best practices related to treatment and prevention of recurrent UTIs. In this area of widespread antibiotic overuse and the prevalence of alarming numbers of multi-drug resistant bacteria, there has been a shift towards non-antimicrobial treatment and prevention strategies. So moving on with our first step, treat acute episode, is the management of acute cystitis. So antimicrobial therapy is recommended because clinical success is significantly more likely in women treated with antimicrobials compared with placebo. According to the EAU and susceptibility patterns in Europe, oral treatment with fosfomycin, nitrofurantoin, or Bactrim should be considered for first-line treatment when available. Also, with the use of ciprobe or fluoroquinolones, the EUA advises caution due to their disabling and potentially long-lasting side effects. These include tendinopathy and Achilles tendon rupture, peripheral neuropathy, QT prolongation, and CNS side effects. And it should only be used if it's considered inappropriate to use other antibiotic or antimicrobial agents rather. Okay. In the treatment of UTIs compared to prophylaxis, the evidence to support the use of non-antimicrobial therapy is not robust. But I will just touch on a few points here that will feed into preventative strategies. So the methods of choice for treatment of acute cystitis non-antimicrobial are cranberry. So the key component of cranberry is believed to be proanthocyanidins, or PCs, particularly type A. These compounds are thought to prevent bacterial adhesion, especially E. coli, to the urothelial cell linings, the bladder and urinary tract. Thus, bacteria cannot attach and therefore flush more easily during urination. The EAU reviewed 3 articles regarding the use of cranberries in treating UTIs. Within all 3 RCTs, the proanthocyanidin content varies significantly from 7.5 to 225 milligrams. And the primary objective of these studies was not to assess cranberry extract as acute cystitis treatment. Hence, the current evidence supporting or opposing the use of cranberry products for managing acute cystitis remains insufficient. D-mannose is a naturally occurring simple sugar. Again, E. coli adheres to the to the bladder cells by fimbria via film H adhesins, which bind specifically to mannose containing receptors on the urothelium. When you take oral D-mannose, it's excreted unchanged in the urine, and those free D-mannose molecules in the urine coats film H on the filmware of the E. coli. This prevents the bacteria from sticking to the bladder wall, which is then flushed out during normal urination. There's again limited data on its use to treat UTIs. Moving on, we have phytotherapeutics or plant-based therapies or herbal extracts. And these are used mainly to prevent or alleviate symptoms of urinary tract infections. And they have several mechanisms of actions, which include anti-adhesion effects similar to D-mannose, anti-inflammatory effects, diuretic effects, which assist with flushing of urine from the bladder, and some antibacterial properties. A study found that BNO1045, which is basically a specific herbal formulation manufactured by the pharmaceutical company Bionorica, was non-inferior to fosfomycin in terms of clinical symptom resolution. And both treatments achieved similar reductions in UTI symptom scores. And even the safety profile of BNO1045 was associated with fewer side effect profiles. In terms of xyloglucan and gellose from tamarind seeds, they assist in a mucosal barrier effect and forms a protective film on the urothelium, reducing bacterial adhesion. Hibiscus contains organic acids and polyphenols, which may acidify the urine, creating a less favorable environment for bacterial growth. Okay, then moving on. If there's an underlying anatomical abnormality, one must correct it. Or if there's other causes of bacterial persistence. These include infectious stones, chronic bacterial prostatitis, foreign bodies, ureteral duplication, non-refluxing, infected urethral cysts. Just to name a few. I won't go too much into the surgical management of these conditions, but it's important to highlight that you need to exclude them before you can move on to your treatment and preventative strategies for recurrent UTIs or recurrent cystitis. Okay, once we have done the previous two steps, we can move on to your prophylactic or prophylaxis mechanisms or means rather. It is a clinically accepted principle that employing behavioral modifications is a reasonable strategy to minimize recurrent UTIs, despite the lack of abundant scientific evidence. Such behavioral modifications carry minimal risk and enhance overall bladder health. These strategies include avoidance of risk factors, which we've already mentioned, hydration, which causes sloughing of urothelial cell and flushing of adherent bacteria. In an open label RCT, it found that additional fluid intake of 1.5 liters a day in premenopausal women with recurrent cystitis, who are low volume drinkers, reduced the number of cystitis episodes and antibiotic usage over a 12-month period. In sexual activity, avoiding pre and post intercourse is also a good behavior modification, and avoiding spermicides because of the mechanisms that we mentioned before, as well as avoiding wiping from back to front after defecation. It is also important to dispel misinformation, such as the idea that shaving pubic hair, wearing inclusive underwear increases the risk of recurrent UTIs, which there's no evidence for. Okay. Then moving on to non-antibiotic prophylaxis, there's a few. The literature surrounding them is still moving forward. So again, there's not robust evidence to show that any one of these has a significant reduction in recurrent UTI risk factor, but it is they are suggested in the algorithm, especially in EU guidelines. So let's start with hormone replacement. So postmenopausal women have decreased circulating circulatory estrogen. So this results in changes in vaginal microflora, which results in loss of lactobacilli and increased colonization of E. coli, atrophic vaginal epithelium, and increases vaginal pH, which basically creates an environment that predisposes towards UPEC pathogenesis. So topical estrogen via the cream pessure tablet has proven to decrease urinary tract infections and takes about 12 weeks to reach its beneficial effect. The local side effects are just burning, itching, and minor bleeding. And the dosage for the cream form or cream preparation is 2 grams daily for 2 weeks, then 1 gram 2 to 3 times per week, Systemic absorption is present for topical estrogen, but very low. And so there's no increased risk for cardiovascular disease and no increased risk of recurrence in breast cancer survivors. Also, recent RCT showed oral estrogen is ineffective in reducing the risk of developing recurrent UTIs. Then moving on to immunoactive prophylaxis. So these are agents that contain heat-killed UPEC strains in order to train the immune system to recognize and rapidly respond to these pathogens before they cause infections, much like any vaccine. And the goal is to reduce recurrence rates and antibiotic use while avoiding resistance. There's a few preparations when it comes to immunoactive prophylaxis. So we'll start with the first one, which is Urovaxom, which is an oral immunostimulant. And essentially, it is made of 18 serotypes of heat-killed uropathogenic E. coli. It works by stimulating the gut-associated lymphoid tissue and increases systemic and urinary IgA and IgG against E. coli antigens, as well as enhancing T cell and macrophage activity. In terms of regimen, it's 1 capsule daily for 90 days. In terms of evidence, multiple RCTs showed 34 to 39% reduction in UTI recurrence rates compared to placebo. And in terms of several meta-analyses as well show that it's a safe and effective method for prevention of recurrent UTIs in the short term in less than 6 months. Then moving on, we have a Urovac, which is a vaginal suppository. Basically, much like Euroimmune, it stimulates Ig and IgG in the urinary tract and subsequently decreases potential colonization of the uropathogens. It includes or is made up of 6 serotypes of uropathogenic E. coli, as well as Proteus vulgaris, Klebsiella pneumonia, and Morganella morgagni, and Enterococcus faecalis. In a meta-analysis done of 3 RCTs, 3 trials were conducted by the same group of investigators. In one trial, the primary immunization was compared with placebo, and in other 2 trials, a booster immunization, which is 3 additional suppositories at monthly intervals, followed the initial primary immunization. What was found was that a slightly reduced recurrent rates compared to the placebo in the other 2 trials where there was a booster. Okay. Moving on to the sublingual spray, Euroimmune, is consisted of inactivated whole bacteria 4 organisms, which include E. coli, Klebsiella pneumonia, Proteus vulgaris, and Enterococcus faecalis. And basically, it's a daily dose over 3 months via spray. Essentially, a prospective RCT, including 240 women aged between the ages of 18 to 75 with recurrent UTIs, were randomized into 3 groups. There was one that had Euroimmune for 3 months, another group that had Euroimmune for 6 months, and another group, or placebo group, that had the placebo for 6 months. And the outcome was to evaluate the number of symptomatic UTIs during the 9-month efficacy period following the 3-month intervention. What they found that Euroimmune roughly halved or bettered the risk of recurrence and increased the proportion of women completely free of UTI over the follow-up period. There was also no added benefit seen for 6 months versus 3 months of treatment in this trial. Then you have Strovac, which is an intramuscular injection, which contains 10 strains of inactivated uropathogens, 6 of E. coli, and as well as Klebsiella pneumonia, Proteus mirabilis, Morganella morgagni, and Enterococcus faecalis. And essentially had 3 intramuscular injections at intervals of 1 to 2 weeks, then a booster injection at 12 months. In a prospective study in patients with uncomplicated recurrent UTIs, it compared Strovac to a placebo. Strovac reduced the number of clinically relevant UTIs. However, again, the literature is not robust on these preventative strategies, so the EAU recommendations are quite weak for them. Moving on to probiotics. The most prevalent commensal organism in the vaginal and periurethral areas is lactobacilli. So certain strains of lactobacilli can interfere with the presence of uropathogenic bacteria in the urogenital epithelium. The maintenance of normal urogenital flora may be enhanced by strains that produce antibacterial substances such as hydrogen peroxide. Most studies conclude that not all lactobacilli strains are effective for vaginal flora restoration and recurrent cystitis prevention. The highest efficacy was shown lactobacilli rhamnosus, reuteri, Caseaceae rota, and crispatus. Although meta-analyses including all known lactobacilli strains did not show a significant treatment benefit, of the 11 systematic reviews, 7 concluded that prophylaxis with vaginal probiotics has a beneficial clinical impact for the prevention of recurrent cystitis. However, again, according to the EUA, the available data is too minimal or of low quality to make recommendations on the route of administration, optimal dosage, and the treatment duration of prophylactic probiotics. Okay. So again, just to touch on cranberry products, it contains type A proanthocyanidins, which again prevents bacterial adherence. Regarding the literature surrounding the efficacy of cranberry products, the results have been contradictory. In the Cochrane review done in 2008, it showed that cranberry products significantly reduced UTIs at 1 year in women with recurrent UTIs. However, an obstacle in drawing conclusions about the efficacy of cranberry is that there was significant heterogeneity of products available and routes of administration, thus making dosage of cranberry in each study population variable. Another Cochrane study done, which added 14 studies to the above 10, cranberry did not significantly reduce recurrent rates at all. So various cranberry formulations were evaluated and compared with a placebo that was either placebo or water or antibiotics or methenamine or lactobacilli or no treatment at all. It was acknowledged, however, that most studies did not report on how much of the PSC that was used, and thus they were questioning whether the medication or the PSC was actually at a higher dosage to be potent enough to achieve the desired result. Based on the prior research, it is advised that 36 milligrams of PSC equivalents per day has been shown to be effective, but 72 milligrams may be even more effective. In the most recent Cochrane review, done with 26 more studies with a total of 50 studies, this review supports the use of cranberry products to prevent UTIs in females with a history of recurrent UTIs, children, and patients who have increased risk of developing UTIs after interventions. Cranberry products are also safe to use with warfarin. This was based on a pre-existing FDA warning to avoid cranberries and cranberry products with taking warfarin, as there was a concern about interactions and increasing INRs and promoting coagulopathy. But this has not been substantiated with any scientific evidence. So yeah, that has been dispelled. Then D-mannose, as I mentioned before, is a simple sugar that prevents bacterial adhesion to the urothelium. It binds and blocks film H and acts as a competitive inhibitor, thus preventing bacterial adhesion. Historically, it has been used for treating UTIs in some animals, from what I remember. Some studies have found that D-mannose was equally as efficacious as nitrofurantoin in reducing the risk of recurrent UTIs and demonstrated a significantly lower risk of adverse effects. D-mannose was also effective in reducing symptoms associated with recurrent cystitis and preventing UTIs. However, Cochrane review, including 719 patients, was unable to determine if D-mannose, when compared to no treatment or other supplements or antibiotics, significantly reduced the number of recurrent cystitis episodes. The overall quality of the evidence was low. The authors concluded that currently available data cannot be used to support or refute the use of D-mannose in the treatment or prevention of recurrent UTIs. Then end-of-cycle installations, with
sorry, man, just a bit pushed for time. Do you still have many slides to go?
I'm almost done.
Okay,
I just have 5 more slides. Sorry. I know it's a long,
no,
it's a very long
no
topic.
shame. It's a large topic. Thanks.
Yeah.
Go for it.
Sorry, I'll try and move. Then just regarding the end-of-cycle installations, we have installations with hyaluronic acid and chondroitin sulfate. The idea is to replenish the gag layer that I mentioned before. And several meta-analyses were done, including RCTs and non-RCTs, that looked at hyaluronic acid and a combination of hyaluronic acid and chondroitin sulfate. And notice there was a reduction in UTI frequency per year and a longer mean UTI recurrence times. They found that hyaluronic acid chondroitin sulfate subgroup actually performed better than hyaluronic acid alone. Then methenamine salts, basically they've been used for urinary infections for approximately 100 years and have still been proven useful to this day. They now occur in 2 preparations, which is methenamine mandolate and hippurate. And how it works is essentially 70 to 90% of methenamine is renally excreted and is converted to ammonia and formaldehyde in an acidic environment with a pH of about 6. So formaldehyde is either bactericidal or bacteriostatic in urine, depending on its concentration. And to achieve adequate acidification of urine, ascorbic acid in the form of vitamin C can be ingested in conjunction with methenamine. The most common side effects of methenamine include GI symptoms, dysuria, rash, and elevated liver enzymes. And methenamine is contraindicated when there's a creat clearance of less than 50, liver disease, or hypersensitivity reactions to the constituents included in these pills. In a Cochrane review done in 2012, in a patient with a normal urinary tract, short-term therapy with methenamine, specifically methenamine hippurate, less than 7 days, resulted in significant reduction in symptomatic UTIs. In a recent RGT in 2022, again, focusing on methenamine hippurate, it was found to be non-inferior to antibiotic prophylaxis in preventing UTIs. There is a theoretical concern of formaldehyde, as it is documented or suspected carcinogen. However, it was found to be carcinogenic or precursor to nasopharyngeal or for nasopharyngeal and sinonasal cancers, but actually has been shown to have no association to urothelial cell carcinoma. So for now, it's just a concern, but there's no evidence to support that. And moving on to antibiotics. Antibiotics have been proven to be the most effective treatment and preventative strategy for recurrent UTIs, but are now being preserved as the last step of the preventive strategies. So self-start therapy is a widespread practice that has been favored for managing patients with recurrent UTIs. It has been reserved for reliable patients to start antimicrobial therapy with onset of the typical UTI symptoms, which allows for patient autonomy and empowerment. Historically, patients would submit a urine sample, start on broad-spectrum antibiotics, and follow up the specimen to evaluate the sensitivity. However, over time, the practice has been a bit muddied, and patients are often given carte blanche when it comes to antibiotic use, which is counterintuitive towards the drive of appropriate antibiotic stewardship. The practice relies on patient self-diagnosis, which was previously assumed to be reliable. But now we see that patients with recurrent UTIs express a lot of anxiety around their repeat episodes, and thus may be hasty to start antibiotics with any lower urinary tract symptoms. The practice is now leaning more towards a strict submission of a urine sample, starting urinary analgesics while awaiting sensitivity, and monitoring for progression of symptoms, and starting antibiotics thereafter once we have gotten the sensitivity or the culture. Then moving on to low-dose continuous prophylaxis and post-coital prophylaxis. These are widely adopted preventive strategies for recurrent UTIs. Essentially, all available meta-analyses concluded that antibiotic prophylaxis is the most effective approach against recurrent UTIs compared with placebo or no treatment. However, due to risk of drug resistance, it is now almost viewed as a last resort. And despite its efficacy, it's not without its own challenges. So in 2004, a Cochrane review of antibiotic prophylaxis against recurrent UTIs in non-pregnant females were conducted. This review included 19 RCTs and reached a few conclusions based on collated data. What they found was that females with uncomplicated recurrent UTIs are less likely to have infection if they take prophylactic antibiotics for 6 to 12 months, although different studies had different time intervals. And although continuous antibiotic use did decrease the clinical and microbiological recurrence rate, however, there were more adverse effects attributed to antibiotics. Also, once the prophylaxis was discontinued, the recurrence rate was comparable between those treated and the placebo group. Therefore, although prophylaxis was deemed an effective strategy in the short term, patients who were treated prophylactically in the long term demonstrated the same risk of recurrence as those not treated at all. They also found that low-dose continuous prophylaxis and post-coital prophylaxis had no significant difference in efficacy. In terms of what antibiotics to choose for chemoprophylaxis, it depends on the local resistance patterns. What I can say is nitrofurantoin does remain a popular choice for prophylaxis because it concentrates in the urine and is very effective against many uropathogens and does not promote widespread resistance. However, it is associated with significant adverse side effects, or adverse effects rather, such as pulmonary fibrosis, renal toxicity, and neurotoxicity, which is something we often overlook when counseling our patients for long-term and short-term chemoprophylaxis. Then intravesical antibiotics. So as the compelling issue of antimicrobial resistance is becoming a serious threat, more research and discussions are currently being conducted about alternative modes of antibiotic administration. Inhalation of therapeutic antibiotics in the bladder is one such last resort option for prophylaxis and treatment of recurrent UTIs. The potential advantage of this is to bypass systemic antibiotic absorption and to avoid the consequent side effects. In 2018, a systematic review was published on the use and effectiveness of intravesical antibiotic treatment, both for treatment and prevention of recurrent UTIs. The drugs examined were gentamicin, neomycin, and polymyxin combination, and colistin. What they saw was that for treatment of UTIs, there was an average reduction of 88%, and for prophylaxis, an average reduction of 71% was seen. Gentamicin was found to be the most effective. However, there were side effects to this, despite not major systemic absorption, such as allergy, suprapubic discomfort, autonomic dysreflexia, and diarrhea. It was found that it reduced UTIs caused by MDR bacteria, and found that there was no systemic absorption and minimal renal toxicity. Okay, so this is just a management guideline we have on the Campbells that actually outline everything quite well, which basically starts off with diagnosing a recurrent UTI. Once it's diagnosed, determining whether it's due to bacterial persistence or infection. If it's persistence, we should investigate for possible nidus. If there's reinfection and we've excluded that there's any upper tract abnormality, then we can move on to the preventive strategies, which comes top to bottom sequentially with behavioral modifications, then your non-antibiotic prophylaxis, then as your last line of defense, antibiotic prophylaxis. Thank you, everyone. Sorry to keep everyone away from work. It was quite a lengthy topic. I tried to keep it brief as possible, and I hope that I managed to impart some kind of knowledge to everyone. Thank you.
Thank you very much, Dr. Chetty. Yes, very, very well.
Lengthy, probably.
Are there any questions from the floor? I think we've lost quite a few participants because of time.
I apologize.
No, it's very big talk to put together. Yeah, I think intravesical, obviously, when we have our children with sort of at Red Cross, for instance, kids that are performing CIC or those with sort of ileocystoplasties, we obviously give empirical, tell them to use gentamicin washouts. I think intravesical gentamicin is obviously something which is very valuable. There's quite a lot of newer research going into it, nanomedicines, almost like that mito gel, which they have for upper tract TCC. So there's ways that they've edited the antibiotic that it's got a longer lasting effect locally without the systemic side effects. So that's definitely something to come into play. I don't know if anyone else have any questions. As I said, yeah, we are a bit pushed. So thank you very much, Dr. Chetty. Excellent. I think you should try and make those slides available because they're very educational. And then, yeah, I'd like to thank both speakers for your contributions this morning. We really appreciate it. There is no webinar next week. It's the Reg Forum, but we'll see you again in 2 weeks. So have a good weekend, everybody.
Thank you.